Top Med Talk.
Well, hello, I'm Desiree Chappell, and this is Top Med Talk. We're coming to you live from the American Association of Nurse Anaesthetists 2019 Annual Congress in Chicago, Illinois. AANA 2019 is a gathering of over 3,000 certified registered nurse anesthetists, or CRNAs, for the largest networking and educational event in nurse anesthesia. Now, this year, the AANA has partnered with Top Med Talk to bring the meeting to our listeners. And over the course of these 3 days, we're sitting down with presenters, AANA leadership, and delegates to discuss hot topics in the CRNA community and anesthesia practice in general. Now, I'm joined, as always, by my co-host, Monty Mythen. Hello, Monty. How are you?
I'm good. Great to be here.
It is great to be here. We've had a very successful 2 days so far.
Yeah, great to be back in Chicago. Keep banging on about that. One of my favourite cities now.
You do love Chicago.
And we touched earlier on about some of the culinary experiences of Chicago.
Yeah.
And, there's great architecture and the history that's here. And we dealt earlier with the complex issues of hot dogs and the fact it's apparently a sin to put ketchup on a hot dog, which I didn't know. Mm-hmm. And then tonight I think we're going on an exploration of something called pizza. It's deep pan or thin crust. Now, I thought pizzas only came on a thin crust. What have I been missing there? No?
You've been missing deep dish pizza.
Okay.
In your
Do I have
life,
to experience
apparently.
that tonight?
Yeah, I think so. I think that's what is on the menu.
So we've settled on Joe Malnati. Am I saying that right?
I have no idea. Why are you asking somebody that's not from Chicago? We need Saul here.
Okay, Saul.
It's Lou. It's Lou Malnati.
Oh, this is our guest.
There we go.
Correcting you.
Lou.
Well, on that note, let's introduce our...
Joe. I'm sorry, Joe. Lou. So we're going tonight to Lou Malnati. So Lou, if you're listening, I know you're a fan. I look forward to seeing you later. And are we going to go deep or thin or both?
I don't know. Well, let's ask our guest.
Okay.
What he recommends. So we've had the opportunity to sit down with some thought leaders within the AANA and CRNAs. And so we had the opportunity to sit down with Brett Kendon. He's a CRNA and the Assistant Program Director at Northern Kentucky University, Director of the Simulation Lab for Nurse Anesthesia, and he's also the Chair of the Simulation Subcommittee for the AANA. And we're going to be talking about simulation in education. So, Brett, thank you so much for sitting down and joining us.
No, thanks for the opportunity. It's exciting.
So our first question is it deep dish, thin crust, or New York style?
Well, I think my friend Michelle Gonzalez would hold me accountable if I didn't say deep dish is definitely the way to go.
Okay.
Yeah.
Right. Well, I look forward to that then.
Well, there you go.
Yeah.
There you go. Well, and so you're not from Chicago,
No,
Brett.
I'm from New Zealand originally.
Okay.
Yeah.
Very good.
Whereabouts in New Zealand?
North Island, West Coast.
Excellent.
Yeah.
Beautiful country up there.
Best rugby team in the world, the All Blacks.
Whoa, easy.
Allegedly.
Oh, we had some discussion about rugby yesterday, didn't we?
Yeah, we did. England were playing Wales yesterday in a warm-up game. I mean, everyone recognises that the scalp is the All Blacks.
Yes,
they don't win every World Cup, but they win most of them. And they're looking pretty darn good at the moment. But some of the other teams are shaping up.
Yeah,
and they've managed pretty strong track record of choking in the World Cup. New Zealand as well.
Oh, wow! Are you serious right now?
No,
what are you doing?
No.
First of all, you're speaking a different language when you're talking about rugby.
2007, for example.
I don't know.
Well, we won't go back to that.
We need to be nice to our guests.
Moving on.
Hello, moving on. So, Brett, tell us a little bit about yourself and your experience there at NKU.
So NKU is a new program. We're just our third cohort is coming into their third year, a new developed program. And one of the exciting things about a new program is we can start it from scratch. So curriculum, all of those type of components. And we're very lucky. Northern Kentucky University just last year did the ribbon cutting for our $100 million simulation center. Oh. So it's a 5-story building just dedicated to healthcare simulation. We have radiology with functional CT scanner. We have a kinetics lab for the athletic training department, respiratory therapy, 4 ICU beds. We have an operating room, piped gases, all of those type of things.
Sounds
so everything
amazing.
is functional
Wow.
in those environments. It's very, very awesome opportunity.
Yeah. How many of those types of labs are around in our region?
Well, it depends on which sort of setting you're in. A lot of large university medical centers have those type of things. The VA is actually a leader in that. They've just built a huge center down in Florida where they want to train all of their VA personnel and sort of cycle them through those simulation opportunities. University of Miami is another big one. They've got a huge, again, 5-story hospital, essentially, simulation hospital. So it's moving forward. People are understanding the importance and the relevance of that as an education modem.
Yeah. Have you had your students in there kind of getting dirty now? And
Oh yeah. No, we incorporate that thread of simulation throughout our program. Absolutely.
Yeah. And what is the reaction of the students when they go into this? Is it
well, it all depends how sort of desensitized they are to it. So if we're a graduate program, so if in their undergraduate bachelor's program, if they've had exposure to it, it's not as different. But those programs that haven't had a lot of it, obviously there's a little bit of a learning curve and a sort of incorporation of that teaching delivery system as well.
How frequently can people get through? Because one of the challenges about simulation is access to getting off work and access to the lab. Is it programmed into everyone's annual?
Yes, so that's exactly part of our curriculum. It's built into their clinical courses, and we consider it a clinical day or clinical experience.
And once you start work, what about the folks when, chaps like myself getting older, do we get access? Do we have an annual trip to the simulator?
We don't specifically have that opportunity, but more of our KYNA, which is our Kentucky State Association meetings, we're embedding simulation opportunities into those. So workshops for neuraxial anesthesia. We have a difficult airway simulation workshop that we're developing for next year. So definitely it's moving forward.
Oh,
Absolutely.
Fantastic. I look forward to that. And then the educators that you have, the groups that can use the sim lab to teach that, you're just bringing in kind of like the anesthesia, what am I trying to say? The
clinicians.
The teams and clinicians.
Yeah, so
to teach.
We have, obviously our faculty, we have core faculty, people that help us, but we obviously reach out to clinicians for experience and as content experts in different areas or specialties. So, for example, before pediatric rotations, we bring them in for a day earlier before they rotate out to their pediatric specialty, and then we run through a whole simulation day of activities just to make sure they're up to speed, thinking in pediatric, the pediatric trainers, smaller airways, those type of things, and then that prepares them better. So when they hit that new environment, they're going to be much more ready and prepared to engage in that environment.
So early on in the days of simulation, simulation intuitively is the right thing to do. But early on in the days of simulation, people were all on about, well, show me the evidence. I think we're beyond that now, aren't we? Don't we accept the fact that it's very helpful, it's the right thing to do?
Yeah, absolutely. Yeah. So early simulation, we think of Resus Annie, maybe doing some BLS training type of thing, a sort of a low reality fidelity component. But now it's moved and transitioned forward so much. And just the evidence that's supporting it is coming from different avenues in healthcare. So on one area is the medicine, medical training, and how they're sort of moving forward. There was a big study from the American Association of Medical Colleges 2011, and they did an across-the-board, they partnered with Society for Simulation Healthcare, National League of Nursing, and a whole bunch of other patient safety organizations to sort of see what's the state of science in medical education across the board. And that really was sort of setting a stage of like, okay, where are we at this point? The next sort of large study that's come out was the National Council on State Board of Nursing. And that study was really interesting. That was nursing-centric. But what they did is they took a class from coming into a bachelor's program for 3 years and then a year out. And they did 10 centers. It was a multi-centered study around the country. It was a huge study. And they actually took them through in different groups, 3 different groups. So the first group of nurses would be dedicated into a 10% simulation. The next was 25%. And then the third was 50%. So of the whole 3 years of their nursing training, they were in the simulation environment and lab for 50% of their clinical experiences.
Oh,
wow.
And then they followed them a year afterwards to see, okay, what was their HESI, their final scores for graduating, what was their clinical competencies up to a year out, and they found that the evidence was that up to 50% is just as effective in attaining competencies and skill level.
Skills.
Yeah. That's
really
the largest study out there, and really one that's referencing and changing, because boards of nursing are now changing the percentages that colleges and training programs are allowed to incorporate into that clinical training.
Now, with the growth of high-fidelity simulation, the sort of large units you're referring to becoming pretty mainstream, I think all of us have got some high-fidelity simulation center access of various different scales. There's been a growth in low fidelity simulation as well. Do you embrace both? I.e., the nearer the patient, let's just remind you, top up on a skill type of thing.
I think it all depends on what we're looking at the objectives and what is the skill level of the practitioner at that time. So if we're doing something, for example, like a basic airway management and training, we don't need a very high-end $80,000 plus trainer for that experience when we're really looking at dexterity and movement and just a sort of a basic skill. So a basic airway trainer is absolutely appropriate for a deliberate practice in order to be able to, start that skill for development. We move into a higher fidelity component, maybe when we're doing a crisis management or intubating under duress, and then we incorporate a whole bunch of contextual influences as to how can that skill now be evaluated with all the other distraction per se, but within a different context. And then we get into critical thinking, problem solving.
And then there's the teamwork aspect of it, which you really need the higher fidelity simulation environment to test teams.
Right, exactly. So we have, essentially on a level 1 per se would be a basic skills training, level 2 moving forward into how that could be incorporated into a situation, and then maybe level 3, how would I be able to lead a group of people, like I say, in a sort of a interprofessional educational perspective of how can we bring all of those components together.
Yeah. So where are you? Where do you think the sim lab is kind of moving? You said we've that's been used on a greater scale. Where do you think it's kind of going now with use in education? I mean, is it something that you just said that the study looked at, greater than 50% utilization in education was actually useful? I mean, do you see that just, adding to what we're already currently?
So I see it as sort of two areas, really. One of them, the first is for a training adjunct and how that can be incorporated or embedded into curriculum. Really, the best way to do it, or think about it, is on Monday morning, they have a didactic lecture or presentation on a certain topic. Tuesday, they get to practice it in the lab. They get to, get some hands-on experience in a simulated environment, and then they put that and translate that into a practice situation where they go to clinical on Friday. If we think of it as a really basic perspective, that's how it fits into the development. We learn about it, we practice with it, and now we apply it. When we're talking on the next level or the different level is the competency evaluation and how you would assess a skill, not the formative or developmental part, but the actual summative or evaluation component. That's really where things are moving forward. And the medical community, again, is an early adopter and embracer of that. So if we think about specific graduate competencies, the dentistry, chiropractic, pharmacology, radiology, cardiology have all got OSCEs or objective structured clinical exams as part of their final demonstration to be able to come board certified. What's most interesting is the American Board of Anesthesiology has now incorporated that third component. So somebody to become board certified as an anesthesiologist has to do the written paperwork, an oral board component, and now they have to do an in-lab competency evaluation to demonstrate competency to be able to come board certified.
Interesting.
So if we're thinking that it's not just the training and development as some terminal high-stakes testing components, which is, again, another incorporation of the simulation components.
So is that something that you guys are looking at within the NKU program? I mean, are you
we do that? We do it sequentially, not necessarily as a terminal, final type of thing, but certainly they have demonstrable skills that they have to do progressively through the program. So they would maybe practice something like neuraxial anesthesia, spinal epidural type of dexterity, things like that, and then they actually have a test out of that skill set. Can they do that? Can they demonstrate it safely and effectively? And we have certain milestones throughout the program where those components are actually built in.
They should be able to do those.
Yeah.
That's interesting. So tell me about the AANA subcommittee for simulation and education and your role in that and where that's going.
So the simulation subcommittee came really from a genesis from a simulation interest group of clinicians and practitioners that we were having meetings at meetings like this, for example, and the Assembly of School Faculty, and just having people together thinking about, hey, what can we do to move simulation, integration, and incorporation in anesthesia education? And so we developed some of the components that we thought were interesting or important to identify within practitioners across the board. So we actually came up with a nurse anesthesia simulation survey, educator survey, and we put that out about 2 years ago and garnered a lot of information where educators were at, their level of experience, their level of incorporation of simulation, and all of these sort of components that we were looking at. And what we did is we compiled that information, and then we presented that to the AANA Education Committee as a potential necessity or identifying the need for a simulation subcommittee to sort of address some of these concerns that are a little bit different and affecting exactly the 120 plus programs we have in the country. So that's where it sort of came about. And the AANA thankfully embraced that and allowed us to proceed. So we're into our second year now at the moment.
So are you going to be working on like developing curriculum and guidelines for what the simulation education looks like?
We really have sort of four main areas of focus in the subcommittee. So the first one is the nurse anesthesia program simulation-based education and how we can sort of assist the educators within programs specifically. So some of those components that we look at is incorporating simulation in curricula, those OSCE or formative and summative evaluation procedures, identification of benchmarks, and program resources that they have access to, and maybe a regional sharing perspective of, okay, maybe can we boot camp together at a certain place to go through these skills. So a part of that actually came out of the survey that a lot of people identified that those were the areas that they were deficient or that they would like some support on. So what our subcommittee doing is putting in recommendations to the education committee for delivery of content at meetings.
Gotcha.
So at the Assembly of School Faculty, or now the ADCE, Didactic Clinical Educators, earlier this year, we actually did a full sort of a very focused simulation perspective, teaching about theory, how you can incorporate these modalities. Those type of things were sort of embedded. Now what we're doing is sort of fine-tuning that a little bit. We actually just had a meeting a couple of days ago on what we would do for 2020. Again, addressing what educators want to know, how we can help and assist, the sort of workshops, those type of things that we can do. The second area is faculty support and development. And again, that sort of tags on to that a little bit, but what are the workshops? What specifically do they want to look at? How can we develop networks? And what are educator-centric components that they need? And then moving into practice and professional standards, which is an area where sort of designing guidelines for nurse anesthesia simulation. There's a couple of large organizations, the Society for Simulation Healthcare and ANAXL, that already have preset standards for types of simulation within healthcare generally and broadly. But what we would like to do is maybe have some ideas specifically related to what we do in nurse anesthesia practice and delivery and education. Another area that we've sort of been thinking about is how can we get maybe some milestone developments. We've got a new clinical evaluation tool that is just starting to roll out, and how would maybe some simulation or evaluation methods and tools be utilized to support that, and what type of innovative CEU or CPC components, instead of maybe online modules,
that's what I was going to ask.
Could we have something regional where, or that we could develop in order to encourage that? So that's just a couple of areas, and then we also want to focus on simulation scholarship, different types of tools. One thing that we're working on at the moment is a valid and reliable tool, an OSCE, essentially a clinical exam for machine checkout. Right now, all the programs in the country are doing different things on how they would check machine checkout and check off someone. Well, let's have a consensus and put that everyone can utilize that. So moving forward, we want to identify what type of components in your axial anesthesia, for example, and what would be a check-off, a valid and reliable tool that people can utilize in the simulation environment. There's a lot of work going on for a lot of people that maybe we can consolidate and collaborate on. The other thing is there an opportunity maybe for simulation-focused doctoral projects within programs that we could, if we're going to be doing one at one center, well, let's talk and maybe we can expand that to the numbers and different environments where we're sort of practicing or utilizing that. One of my projects that we have going on at the moment is ultrasound evaluation of gastric content for aspiration risk using a simulation-based education modality, pre-post test for proficiency, comfort level, those type of things. So I think there's a lot of opportunity that we can sort of talk about, collaborate on, and progress in the scholarship arena. And then one of the main things that we're doing at the moment is the survey that we had done informally from the special interest group, we're actually formalizing that into a large survey through all programs to evaluate, again, what resources faculty have, what utilization of simulation in their programs, deficits and barriers that may be needing to overcome, financial restrictions, and then develop a white paper based on all of that information. So we get a state of science within nurse anesthesia education, programs, educators, and where are we at the moment? Are we consistent with what is developing and happening in healthcare? Or here are some recommendations that maybe can move us forward. So that's really the big task that we're working on at the moment, is getting that white paper developed, and that we're based on that survey. Wow. Lots of valuable information.
A lot of work.
That is a lot of work. My gosh, you guys are busy.
Yeah. So
that's
what we do.
Those are great initiatives. I mean, it sounds like, this simulation can be, and sounds like it will be a large component of education for our upcoming CRNAs. And hopefully, as Monty said, one of the questions I had is, as a provider that's been out for a while, being able to get into that sim lab, that if I haven't done, I haven't done OB in years, but it's something I would like to kind of, start doing again. Do we have the opportunity to kind of get in the sim lab to do something like that?
Or even just a regional workshop.
Yeah.
Like the difficult airway initiative that we're thinking about doing for members of the KYNA, not necessarily just centric to programs, but clinicians in general.
Yeah.
What would they like? And here's just a different way or modality to learn that skill and task. So
yeah. No, I think it sounds great. Thank you for all the work that you're doing.
Thank you. It's not just myself. There's a
whole team of it.
Group in the simulation subcommittee, and then in the expanded interest group. Educators from all over the country and all programs are very interested in supporting and moving this sort of initiative forward and getting some consensus within our profession.
Where do you think simulation's going next? Let's take virtual reality, for example. Am I going to be able to put my VR goggles at home and come to your sim center? So
there's a lot of movement towards that. Yeah. If we look at there's a paper that gets put out every year to the 100 most cited articles in healthcare simulation education, and virtual reality and past task trainers specifically related to virtual or embedded reality was about 14% of all the papers written on healthcare simulation. So there's definitely a movement towards that. My personal feeling on that is, if we're going to be utilizing a technology, what is the benefit and how is it going to develop the skill? If we're using it, example, for ACLS, there's some virtual reality programs out there, goggles, things like that you can do ACLS processing. That's great. If that is specific and the objectives are being met, then that's great. But I don't necessarily see a high utilization of that technology yet. One that we do have embraced is virtual reality bronchoscope. It's called OR Sim, and it's a specific virtual reality bronchoscope that our students train on. And you can pick different anatomy, pharyngeal abscesses, get different types of things, but it definitely works on dexterity and movement. And that translation into the OR is extremely significant. I've had students that have practiced on that, haven't had a real double lumen tube or, used a bronchoscope before, go in for first time, and actually the surgeons in the room have said, that was an amazing demonstration for the first time. Yeah. Relate that back to, because we've practiced under that virtual reality modality. But again, I see specific pockets, not just that's the way everything's heading in general.
So what else would you pick off the list from your perspective of the 100 most cited articles? What do you think is going to be coming our way soon?
Yeah.
One of the changes was moving from mannequins into a standardized patient situation. Okay. So the mannequins that we have, obviously they can vomit, they can seize, they can do all of these sort of fancy things, but the interaction isn't necessarily there. So there's a movement towards standardized patient, which is a person playing a role, like an actor per se, but having some components of simulation built into that interaction. So obviously we have communication, but we can move that forward with different devices. So one of them is our wearables. So they can actually have a T-shirt or a shirt overlay that's actually embedded with different magnets is one of the examples. And when they put a stethoscope onto that patient, that magnet triggers a certain sound. So heart sounds and lung sounds can actually be changed based on that. Or they can wear a device on their abdomen that when they're being ultrasounded, they can get different types of anatomy.
So it's a human being in the bed, and when you put the stethoscope on, you're listening to mitral valve prolapse 1 minute, you're listening to aortic stenosis the next.
That's exactly right.
Brilliant.
Oh, that is really cool.
There's one that's the wearable, and then there's another one that I really like. It's actually a Bluetooth stethoscope. So from my iPad, I can actually, they just put it onto the patient, and I can just dictate what is being presented through that stethoscope in real time. It's a little less hassle per se than, and how many T-shirts do we need of different sizes sort of thing. So,
but with the ultrasound, for example, you'll get you're pressing a bit hard there, doctor, and that jelly was a bit cold. It's a bit more of interactive feedback, and certainly they can do wearables for peripheral IV placement, different type of arterial line overlays, things like that. So I see a movement there where we have an interactive, not just a static sort of trainer situation.
Yeah. Well, fantastic. Well, Brett, thank you so much for sitting down with us and chatting about this. I think it's fascinating and something really to look forward to.
Is there anything we didn't cover off?
Yeah.
No.
Good.
Brilliant.
Yeah.
Well
I think
done.
we've covered.
Want to come and see your centre?
I know, me too. I'm coming up.
Yeah. Absolutely.
Maybe for the meeting to be able to make one of the breakout session or workshops over there.
Or just if you're in the area and moving through, just you feel free to email me and just say, hey, can I stop by and just have a look and see what's around?
Yeah, that would be great. Absolutely. So, well, again, thank you for sharing this knowledge and the information about the subcommittee. If people want to get a hold of you or anyone else on the subcommittee because they're interested in this facet of anesthesia, what's the best way to do that?
So one of the things that we've actually developed in cooperation with the AANA was the AANA Connect simulation site. So we actually have a specific simulation-focused site on AANA Connect for sharing, collaboration. People are just putting ideas before we go to meetings, or we post what we've been discussing at the meetings as a sort of an outreach. So that's a really good method for people. They can chat independently or within the group. And again, information or sharing of different components like OSCEs or checklists, things like that. Or they can feel free to email me at kendonb1@nku.edu.
And we can put that in the show notes too, so that'll be great. Because there are a lot of people that listen that aren't in the anesthesia community, may not be on AA Connect, but may have nursing communities or medical that would like to get involved and work together. So
absolutely,
that's great. Well, again, thank you for the hard work that you're doing. It's much needed, and congrats on the NKU program.
Thank you.
And it sounds like it's going gangbusters.
It is. It's great.
And where are we going to be watching the Rugby World Cup final? Are you going?
No. I was lucky enough a couple of years ago when I was in New Zealand, my 6-month pregnant wife allowed me to go to the national, the World Cup rugby in New Zealand. So I think that's my one time. Exactly.
All right. Well, Brett, we look forward to hopefully talking to you again on Top Med Talk. Thanks to all of our listeners. If you've been listening during AA 2019, you can hear other podcasts that we've done. You can go on topmedtalk.com and find it there, or we're of course on the Twitter sphere, Facebook, LinkedIn. We even have some pics on Instagram, I believe, that have been up there for a little while, so check that out.
Maybe one from Lou Malnati.
Maybe they're going to criticize your pronunciation. And again, like I said, check us out on topmedtalk.com. So thanks for listening. Cheers.
Top Med Talk.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.